All right, this PowerPoint presentation is on our new drug that we were able to um, get put into our protocols, D10. So this is a new protocol, and I'm going to say it's a new paradigm shift, okay? And so this, we're going to try to just briefly delve into the down low on D10 and D50. So and we've been using D50 to correct hypoglycemia in patients since way before I became a paramedic, which I know was about when rocks were formed. Um, so we were taught about the dangerous insulin shock, the hypoglycemia is to our brains and all that, and that we needed to quickly reverse that. D50 was kind of our only option for years. Um, Glucagon came into the mix, and we use that sometimes as well. But that correcting that hypoglycemia, I want you to consider kind of the path that the patients have to take after we slam them with D50. So that aftermath of giving a concentrated glucose dose of what we do. I know that we don't need to see them for very long. Our pre-hospital interactions with them sometimes are not that long, but the journey that the patients have to take, and sometimes in the emergency department and in the hospital, sometimes it takes a while to get them back to their baseline. And I've anecdotally heard patients, especially now that I've been given D50 for a while, when I wake them up and tell them that we gave them D10 and how much their sugar was now, they say, oh my gosh, thank you for not spiking my sugar so much. It takes me days to get it back to where I need to, and I just don't feel well. And again, that's an anecdotal thing. That's stuff that people have just said to me since I started using some D10 instead of D50. So, we're here to do no harm. We're here to help people. All of our, I think the insides of us, we want to give people the best care that we can. And so this is just a little journey to help you make your own decision on the benefits of using D10 and trying to get that D50 out of our heads maybe. Okay, so here we go. Okay, like we said, D50 has been a pre-hospital tradition for a long time, and I want you to think, should we continue this? That's what this is about. Can we use a medication that has less side effects and is safer and quite frankly cheaper and usually not on our back order list? Okay, folks, we are going to look at some properties that D50 has, and number one is that it is a hypertonic nutrient replenisher. Now, what is this hypertonic thing? Um, Many of you know that tonicity is a measure of the osmotic pressure gradient, okay? Relative concentration of solutes, or the particles dissolved in a solution, is that pressure gradient, okay? This pressure gradient determines the direction of movement of water and diffusion. And diffusion is the movement of particles, osmosis is the movement of water. So the tonicity that a solution has doesn't move the particles per se, but it exerts an osmotic pressure. And that moves solutions or water in our bodies from one compartment to another. So a hypertonic solution has a greater concentration of solutes, or the little particles, and in D50 is the D50 glucose particles. And a hypertonic solution has more solutes or particles than what is in the cell. So since the solution we are giving, that D50, is hypertonic, the water from the cells will cross out of that semi-permeable membrane and attempt to make that hypertonic fluid that we're giving within the vessels, make that equal on both sides of that cell membrane. So what that does is draw fluids from the cell into the vessel, which effectively dehydrates our cells. So we kind of understand this pathophysiology when we think about diabetic ketoacidosis and how they have fluid shifts when they have those increased glucose levels in their system. Honestly, one of the problems with giving D50 is that we're essentially causing a cellular dehydration because of that movement of fluid. So that being said, it is kind of in my mind an iatrogenic issue that I am causing by giving D50. If I don't fluid resuscitate that patient as well and give a bolus of saline as I'm giving that D50, then I am essentially causing a dehydration of their cells. And just think about when the last time you started an infusion of saline on your DKA patient and let that infuse in after you gave the D50. We usually give some and then we go, okay, they're waking up, and we DC it and have them sign the refusal. So I'm just trying to help you figure out what all this means, this stuff. Okay, number 2 here is that a property of D50 is that 1 milliliter contains 0.5 grams of dextrose, or there's 5 grams in 10 milliliters. Okay, D10, as you see in the parentheses here, has 5 grams in 100 milliliters of a solution. So we're giving a little bit more solution than just that dextrose. Now let's look at the osmolarity of D50 versus D10. We can see the osmolarity of D50 is 2,525 milliosmoles per liter, and D10 is 505 milliosmoles per liter. So what does that mean? Osmolarity, or the osmotic concentration, is pretty cool to figure out. So that is the concentration of a solution expressed in that total number of solute particles per liter. So our normal plasma osmolarity is 290 milliosmoles per liter. And as you can see, that the D10 is 505 milliosmoles per liter, which is a little bit more than normal plasma. But how much of a difference is that D50? 2,525 milliosmoles per liter. So pretty high osmolarity. Solutions within that same concentration as plasma, those are called isotonic or isoosmotic. So if they're the same as our plasma osmolarity, then it's the same, and that fluid shift doesn't happen. So why do I care? It's that whole isotonic solutions don't cause that net movement of fluid, nor does it cause it causes endothelial cell walls to be damaged when we push a bolus of medication. So let me say that again. Isotonic solutions don't cause a net movement of fluid, and it doesn't cause an endothelial cell wall to be damaged, which can cause leaky endothelial cell walls. Hypertonic or hyperosmolar solution draws fluid from the cells, like we just mentioned, and can damage the endothelium, and that causes damage to that cell wall and can cause leakiness. So let me tell you what the Infusion Nursing Society published. They publish recommendations for infusing medications and how fast to do it, what kind of veins you need, what if you need a central line, and that sort of thing. And this is based on the pH and other factors like tonicity and stuff. And there's direct relationships between the pH and osmolarity of an infusion or an infusate and the development of phlebitis. And that makes sense. So phlebitis is that irritation and inflammation of that vessel. So if I'm infusing something that's really, you know, almost like caustic, it's just very, very hypertonic, it's going to cause more often a phlebitis reaction to that vessel. The lowest risk is an osmolarity of what you're infusing lower than 450 milliosmoles per liter. Moderate risk of phlebitis occurs between 450 and 600 milliosmoles per liter. And the highest risk for phlebitis occurs when the solution osmolarity exceeds 600 milliosmoles per liter. And what did we say the osmolarity of D50 was? 2500, right? And that D10 was 505. So we have a high risk of phlebitis with the D50, and we have a moderate risk with the D10. So they also, this Infusion Nursing Society defined, you know, what vessels should have a low risk or a moderate risk or high risk. And so what they stated was that when an infusion has osmolarity of 500 or so milliosmoles per liter, that's the outer limit of what a peripheral vein can tolerate, just due to the irritation that osmolarity can cause. So some of the other resources that I found actually say IV infusion resources that state that medications with an osmolarity of 900 or greater should be given via central vein only. And again, look at what the osmolarity of D50 is, 2500. So we technically should be only giving that in a central line, or just the phlebitis part of it. Number 4 is talking about pH levels and acidosis. So the pH of D50 is between 3.2 and 6.5, which has an average of about 4.2. So it's pretty dang acidic, right? D10 is about the same, it's just a little bit less. So what are the pH levels that damage those endothelial cells? So we were talking about the tonicity and osmolarity. Now let's look at the pH level in that damage. So obviously a pH near 7.4, the less damage occurs, because that's, you know, 7.35 and 7.45 is normal for our bodies. So in test tube experiments, a solution with a pH value of 2.3 kills venous endothelial cells on contact. Okay, so the endothelial cells that are at the end of our IV catheters, right there where the beginning of that catheter starts in that vessel, they have the fluid hit that part of that endothelial tissue. It stays there longer because it's more, it's more concentrated right there. And due to that increased time of exposure, it causes perfectly patent lines, causes them to start to leak, and the IV infiltrates during a medication infusion. And this is why when we give D50, and this is how I teach it to my advanced students, is you give about 10 mils, let that infuse in with some fluid, and then when you're ready to do more, you draw back to make sure that it hasn't infiltrated. When you get blood return, then you can give 10 more, followed that by a bolus of fluid. And then when you're ready to give more, you draw back, make sure you have that blood return, and then you give 10 more mils. So it should take you a fairly long time to give your D50 if you're doing it correctly and with the least amount of potential damage to the vessel wall, the endothelium in that vessel wall. So that's kind of why sometimes when we're given medications, whether it be D50 or whatever, we're flowing that through. And right at the end there, of that catheter, is where the concentration is the most. And sometimes that is enough to damage the endothelial cells there in that vessel, and it makes that line that was patent just a second ago infiltrating. So it's kind of interesting, I think. All right, so number 5 here contains sodium hydroxide and or hydrochloric acid for pH adjustment. So sodium hydroxide is lye. It's base or alkalytic. And what is hydrochloric acid? Pretty acidic. So during manufacturing, this stuff is used, these sodium hydroxide and hydrochloric acid is used to help ensure the stability and the shelf life of that medication. So here's an interesting fact. If you've ever wondered, like when you're told, hey, don't give epinephrine and sodium bicarbonate the same line, back to back. You have to flush out one of them before you give the other, or it forms precipitates. So have you ever wondered why those precipitates form when you mix some of those medications in an IV line? So if we are giving a medication or preparing to give a medication and we alter the pH from a high pH level, that needs to be, that way to ensure the efficacy or the solubility of that solution. And if you change that pH level quickly in that line from the medication or the IV fluid and the medication mixing together, or two medications mixing together, that is when that precipitate exists. It forms, So if we change that pH from a high pH to a lower pH by what we're giving, or vice versa, it will cause that precipitate to form. So I'm going to just do that example of epinephrine and bicarbonate. Bicarbonate has a pH of 8 and 2,000 milliosmoles per liter, and epinephrine has a pH of 3.3. And a 270 milliosmoles per liter. So there's quite a big difference there. So you're going to be mixing those two medications in the same IV line because of the change of that from high to low or low to high pH. It forms that precipitate. So I think it's pretty interesting, and we don't want to do that. Okay. Okay. So D50 actually has warnings on the label, which not the label on the box, but inside. And I didn't really pay attention, haven't really paid attention to this, but obviously it says it may cause phlebitis and thrombosis at the site, and we kind of talked about why. It can cause hyperosmolar syndrome with too rapid of an administration. And hyperosmolar syndrome is a medical emergency that is caused by a very high glucose level. And this osmolarity increases with increased sugar in the vessels, as you know, and so it's hyperosmolar syndrome. So when we give a hypertonic solution, we're causing that if we give it too fast. Some of the signs and symptoms that we can see for hyperosmolar syndrome are the altered level of consciousness, the polydipsia, dry mouth, polyuria, tachycardia, shortness of breath. They can get dry skin, and with the changes in electrolytes like potassium and sodium, we can have ECG changes as well. So another warning on the label, it says it can cause fluid or solute overload, dilution of serum electrolyte concentrations, overhydration, and pulmonary edema. So interesting. It's not benign. Okay, some of the precautions that D50 has is that when you're administering it, to minimize that hyperglycemia that can happen, and glycosuria, which is basically glucose in the urine, you're supposed to give a little bit and monitor the blood glucose readings. So most of the time our body doesn't have any glucose in the urine because the kidneys are able to reabsorb it and everything's good. If we go over about 160 to 100 milligrams per deciliter, our body isn't able to fully reabsorb that glucose, and so it spills it into the urine. So in order to minimize that problem, we're just supposed to give it very slowly. So it states in there that the maximum rate that should be infused without producing glycosuria is 0.5 grams per kilogram of body weight per hour. And that's not that much. So 0.8 grams per kilogram per hour helps about 95% of the dextrose to be retained and not spilled over into the urine. So what that equates to is roughly giving a 100 kilogram patient the whole D50 in 30 minutes, and a 50 kilogram patient over 1 hour. And how many times have you guys stayed on scene to give D50 to your 50 kilogram patient for an entire hour, given that slow? Not so much. Okay, now I've heard the argument over and over. Hey, D50 has to be faster at getting your patient back to alert and oriented, right? Because it's more concentrated. And what I say is it, Mitchell? Is it? If you're a fan. Anyway, somebody had to do the study, right? So that's what we're going to go over next. All right, this randomized control trial, and I cited one of the published sources here, dextrose 10% or 50% in the treatment of hypoglycemia out of hospital. All right, and they had in October 2002, and this was a long time ago, guys, to October 2003, participants were enrolled based on identified inclusion criteria. And this criteria included that they were 18 years of age or older, that their level of consciousness and ability to cooperate did not allow administration of oral carbohydrates, so they had to be fairly confused and unable to follow commands, that their blood glucose was roughly 72 milligrams per deciliter or lower, and that IV access was obtained within 3 or fewer attempts. So some of the stuff that they excluded the patients for was if they were cooperative and conscious enough to receive oral glucose, then they didn't get randomized into this study. And if they had received glucagon prior to EMS arrival, because there would be no way to say, oh, it was the D10 when it could have been the glucagon. And if they were already given oral glucose prior to EMS arrival. So that was the inclusion and exclusion criteria for this study. And there were 54 participants that were randomized in this study, and they wanted to compare the efficacy and safety of giving 5-gram aliquots of 10% and 50% dextrose in the out-of-hospital treatment for adult hypoglycemic patients, and that's what they were studying. And you might say, what is an aliquot? It has nothing to do with the cousin of kumquats, just so you know. It has everything to do with giving a smaller part of a whole. So say I was going to try to give that whole D50, that whole entire amp of that, and I do it in small aliquots of 5 grams at a time, or small doses of 5 grams at a time. That's what that means. It's not a word I made up, I promise. Okay, so they randomized these patients to either receive the D10 or the D50, and they were testing the 5-gram increments. So with the D10 concentration, that was 50 milliliters at a time, and then the D50, that was 10 milliliters at a time. The providers were instructed to wait for 1 minute in between those little aliquots before administering the next dose, until their endpoint was until the Glasgow Coma Scale returned to 15 or the maximum cumulative dose of 25 grams of dextrose was administered. Okay, the primary outcome measurements that they were doing was to compare the time taken to regain that Glasgow Coma Scale up to 15 following the administration of either that D10 or the D50. One of the secondary outcomes included post-treatment blood glucose levels and the total dose of dextrose given, and the time to achieve a blood glucose level of roughly 81 milligrams per deciliter. And then the researchers followed up all the patients to determine if there was a recurrent episode of hypoglycemia within 24 hours of the treatment they received. Okay, here were the results. Here's what they found. That there was no significant differences between the groups in time to recovery of that Glasgow Coma Scale of 15. Each group was roughly 8 minutes. The D50 group, it took 8 minutes, and the D10 group, it took 8 minutes. So there's no differences in median post-treatment Glasgow Coma Scale. Okay. Um, the proportion of participants experienced the further hypoglycemic episode within that 24 hours afterwards was the same. It was 4 in each group. So not a big difference there either. So what this suggests is that the higher concentrations of dextrose containing fluids do not expedite reversal of hypoglycemia as compared to the lower concentrations. And what have we been talking about with the lower concentrations? That they're so much safer to give on that patient and so much easier on that patient. So riddle me this, Batman. Why are we still advocating the use of D50? Okay, here were some more of the results that they published. The post-treatment blood glucose levels in the D10 group was 111 milligrams per deciliter. The post-treatment blood glucose levels in the D50 group was 169 milligrams per deciliter. What did we say about glycosuria? That between 160 and 180 milligrams per deciliter is when we start to move that, to lose some of that filtered stuff, and it spills over into the urine. I didn't say that very well, did I? So also the number of patients that received the max dose of 25 grams in the 10% group was 3 out of 25. They received the whole 25 grams, and the number receiving the max dose of 25 grams in the 50% dextrose group was 17 out of 26. So to further let you know some more results, that 2 of the subjects that were contacted by the researchers after the treatment, they reported that before this study, they had often had difficulty bringing their blood glucoses back to their expected levels after being treated by the D50 dextrose by paramedics. So it's a struggle for them. So could the D10 help our patients return to their normal faster and easier? Evidence suggests that administration of dextrose can have a detrimental effect on patients' risk of cerebral ischemia, such as victims of stroke, cardiac arrest, or head trauma. So, okay, so a little bit more about what the science says. Theoretically, administration of D50 can cause rebound hypoglycemia. This hasn't been really vetted out in studies. But after D50 administration, there's usually an excess of glucose available. That makes sense. This leads to an increased uptake and utilization by the tissues. That suppresses both gluconeogenesis, that's the generation of glucose from non-carbohydrate substrates, and glycogenolysis. That is the breakdown of glycogen to glucose from muscles and liver sources. So if you give a bunch of D50 and that hyperglycemia happens without continued administration of dextrose containing fluids like D5 or D10 or something, that can result in rebound hypoglycemia. And again, it's not well documented, but theoretically it seems to be a potential problem of administering D50. Number 2 here, overshooting glycemic targets. So we've kind of already talked about this. The several studies have reported post-administration glucose levels between 160 and 250 grams per deciliter. In one study, both rapid increases in glucose and subsequent glycemic variability, and that variability are swings in blood glucose levels. Okay, so hypo, hyper, hyper, hypo, and that increased the overall morbidity and mortality in critically ill patients. So it doesn't help the patient. So maybe we should use something that doesn't cause that variability in the swings in the glucose levels. We already talked about hypertonic tonicity, and remember that D50 has a greater osmolarity than D10, and it has a greater osmolarity than 8.4% sodium bicarbonate, and we know that that is pretty hypertonic. The If you remember, the D50 is around 2,500 milliosmoles per liter, and that sodium bicarbonate that we give is around 2,000 milliosmoles per liter. And remember that most textbooks recommend that over 900 milliosmoles per liter be given through a central line. And again, just a reminder, the osmolarity of D10 is about 500 milliosmoles per liter, much lower. So the rate of extravasation or infiltration from these hypertonic solutions has really been cited to be as high as 10 to 30% of that. Think about D50 extravasating into the tissues at 10 to 30% of the time. That's a lot. And that hyperglycemia can cause cerebral edema in children. Most of that has been studied with treating diabetic ketoacidosis in children and that cerebral edema happening. And it can be a very, very high mortality rate for those kids, and we don't want to make it worse. So that's kind of what the evidence says. So are we doing the right thing when we give D50? Okay, this is my not even one slide. All right, so how about we get on the bandwagon and just do no harm. Just don't give D50. Can we do it? Yes, we can. Those of you that have little kids kind of probably know what that was. But I just wanted to give you some of the science behind the differences between D50 and D10 and kind of get some thoughts in your mind of let's just stop giving it. All right, and the next slide we have a little bit of financial comparisons. As you know, we have kind of a rolling shortage of medications, but I just wanted to give you what Joe told me. She orders this stuff, what the prices are. So the bag of D10 are about $6.50 each, and an amp of D50 is $13.12 a piece. And D50's been on shortage back and forth. D10 kind of is sometimes too, but hasn't been quite as often. So that's a couple of reasons right there. Stop giving D50. Have you guys made your decision? Come to your own conclusions yet? Okay. I thought I would address a good way to give this D10. Small doses seem to be a little bit smarter to give, right? So it's more controlled. We don't overshoot as much. So I think giving maybe 5 grams at a time, that would be about a 50 milliliter bolus. Wait a minute, let some normal saline run in if you have it piggybacked into your saline. And then wait for a bit, see if they become oriented. If not, go ahead and bolus them some more. And you can just do that until they are oriented and you're checking their sugar and it is over that 80 milligrams per deciliter. So what do you think? All right, that is it. And I appreciate you guys listening to me. I appreciate you guys being so open to that change word. This isn't, to me, this isn't rocket science, and it's amazing to me how fast you guys have changed your way of thinking already with the D10. I'm proud of you. You're not afraid of that change word, and that goes to say something for you guys. So I appreciate you. Keep up the good work. Be safe out there, and I'll see ya soon.